Good evening, everyone. We welcome you all to Ortho TV in association with Orthopedic Research and Education Foundation. To introduce today's speaker and topic, I hand over to Dr. John Mukhopadhyay, Chairman of Oref.
Good evening, everybody, and thank you, Neeraj. Welcome to this edition of Tuesday evening CME programs brought to you by Orthopedic Research and Education Foundation with Ortho TV. After a small gap, as I was traveling, we have this meeting again today, and today we have Dr. Ratnesh Singh, who's going to talk to us about total hip replacement, especially with protrusio Acetabuli. So I think without much further ado, I'll hand it over to Ratnesh to give his talk today. Thanks, Ratnesh.
Yeah. Good evening, sir. Today I shall discuss about total hip replacement in protrusio Acetabuli. But before jumping to the total hip replacement, let's first know what is protrusio Acetabuli, some basics. By definition, it is intrapelvic displacement of acetabulum and femoral head. Femoral head usually projects medial to the ilioischial line. It is a straight line from ischium. It is a curved line from ilium to ischium, and any migration medial to it is considered as protrusio Acetabuli. It was first described by a German pathologist in 1884, William Otto. He described it as an orange inside the pelvis. So sometimes it is also called as otopelvis. In 1909, Ippinger described 4 similar specimens as delayed ossification of triradiate cartilage. He considered that delayed ossification of triradiate cartilage is the main cause. In 1929, Doob described 50 cases as a generalized disease of the childhood. In 1932, Pamrenges described only 2 etiology. According to him, there are only 2 etiology for protrusio. One is infection and another is osteomalacia. In 1939, Gilmer described what we read today and what we consider the causes as primary and secondary. Etiology is primary and secondary. Primary is basically the diagnosis of exclusion when there is no visible cause, usually seen in young middle-aged females. The causes could be osteomalacia or sometimes some infection. The 4 important causes of secondary is rheumatoid arthritis, osteomalacia, Paget's disease, and renal osteodystrophy. These are the causes these are the detailed list for your exam oriented thing. First is infection. Tuberculosis is more common in India. In inflammatory condition, rheumatoid is more common in India. Metabolic Paget's are not so common, but yes, osteomalacia is one of the cause of protrusio in India. Marfan syndrome is also one of the common cause. In primary neoplasm, hemangioma is the cause. And nowadays, we see acetabular fractures as a secondary cause of protrusio Acetabuli. Sometimes the condition is bilateral. In case of bilateral protrusio Acetabuli, you must think of the cause and treat the cause first. Only surgery will not do the full treatment unless we treat the underlying cause. Most common causes of unilateral is failed hemiarthroplasty, acetabular fractures, rather post-acetabular fractures, tuberculosis, failed THR, and fibrous dysplasia. How do we assess the protrusio Acetabuli in normal AP X-ray? First, we have to see the ilioischial line, or what we call it the collar line. Any medial migration of the head or acetabulum beyond this point will be considered as protrusio. There will be break in the sentence line, Another thing is the angle of V-work. It is the central edge angle. A vertical is drawn on the center of the head, and another line is drawn to the edge of the acetabulum. This makes the angle of V-work. If it is more than 35 degree, it is considered protrusio. There is one more thing which is more common, even that is preserved in revision situation, that is this teardrop. If any migration is medial to this teardrop, if nothing is seen properly, the teardrop is most of the time preserved. Any medial migration to this teardrop is also considered as protrusio. Now the classification. Classification is given by Chanley and his fellow Sotelo. This classification is based on the medial migration of acetabulum beyond Kohler's line. It is considered as grade 0 when there is no protrusio, grade 1 when there is mild 0 to 5 mm of medial migration, grade 2 is moderate 6 to 15 mm of migration, and grade 3 is severe more than 15 mm of migration beyond Kohler's line. Although this classification does not help much in the treatment of protrusio acetabuli. Now the treatment options. First, we have to see the age. What is the age of the patient, whether he is skeletally matured or immature. Secondly, we have to see the cause. Suppose it is due to rheumatoid arthritis or could be due to the tuberculosis, and we have to treat for the primary cause first. In skeletally immature patients, the treatment of choice is tri-radiate closure plus VITO, that is valgus intertrochanteric osteotomy. In very young adults, yeah, sometimes VITO is the option, but in adults, THR is most preferred option. This is the pictorial representation of valgus intertrochanteric osteotomy. Here we make it valgus to change the forces. Personally, I don't have any experience of this VITO or closure of tri-radiate cartilage. Now, what are the problems we face in protrusio acetabuli? There is medial and proximal migration of hip center. That leads to shortening and decreased range of motion. There is deficiency of medial bone stock and reduced peripheral bone support also. In cases of rheumatoid arthritis, the bone quality is also not good. So that makes replacement a little bit tough. Now the goals in THR, what we want to achieve after THR. First, we have to restore the hip center. We cannot keep the hip center too much medial because that can lead to the early failure due to increased loading of the implant. If we keep the hip center too much lateral, there will be less small lever arm that will cause the pain in the abductor muscles. So there is one term which is called profunda. Neither we have to keep in protrusio, not too much lateral, just keep at the level of teardrop. So the medial part of the hip cup should be at the level of teardrop. That should be our target to to restore the hip center. Second thing is to restore the limb length. Once you restore the hip center, limb length is most of the time automatically restored. And another goal is to build medial bone stock. That will prevent recurrent protrusion and any future possible revisions. For any future possible revisions, we need the bone stock there. Now the implant choices. There is a cemented cup and cage, or uncemented cup. These are the results published in the International Journal of Contemporary Medical Research in May 2020. According to this, only cemented cup has the poor prognosis. The best result is with the impaction bone grafting and uncemented cup. Impaction bone grafting and cemented polythene cup has results slightly inferior to uncemented one, but that depends upon who is presenting. Some of the authors have shown excellent results. Some others are now showing that uncemented cups do better with the impaction bone grafting. So cemented cup. If we do only cemented cup and try to fill the gap with the cement, there is high chances of failure. So we do this sandwich technique. First, we do the impaction bone grafting. Impaction bone grafting, here we keep the bone graft in small particles like 4 to 6 mm size, and it's packed very tightly. And over that, we use flange cup with the cement. This flange cup help to pressurize the cement. So this technique works well and it helps in restoration of medial bone stock. And by the time it heals, it gives a very stable construct. Another choice is cage. There are many cages present, that is anti-protrusio cage, but that doesn't mean we should directly jump to the anti-protrusio cage. These cages should be used when there is pelvic dissociation, like in conditions when there is medial wall defect is more than 3 centimeter, and when superior migration is more than medial migration, because in superior migrations usually bone grafts doesn't do better. In weight bearing areas there is high chances of failure of bone graft, so you need a strong support there. If we use the cage and medial bone grafting, that works very well. Suppose this cage even work for the 10 year, 15 year, 20 year. We can remove that cage, then we will have this medial bone. We will have this medial bone stock over which we can use a normal cup. Most preferred treatment nowadays is uncemented cup with impaction bone grafting. The advantage of this technique is it restores medial bone stock. It's a biological fixation. It restores hip center and long-term survivorship is better. Now, surgical point of view, while we do the exposure, we have to be very cautious for the sciatic nerves because it comes really very close to the joint. We should always search for sciatic nerve before cutting any structure if we are going through posterior approach. Always attempt to dislocate the joint. That doesn't mean you have to fracture the shaft. Always attempt means slowly attempt the dislocation and find the tight structures. What are the tight structures you find? You cut it, you release all the structures so that after surgery you will get a good movement. If you just cut the head directly, cut the neck directly and dislocate, don't try to dislocate, then there shall be many tight structures left in the joint and post-op movement will be less. Always remove all marginal osteophytes that will narrow the acetabulum margin around the neck, and circumcision of the capsule. That means 360-degree cut the capsule and then excise labrum over hanging osteophyte. These all will help in dislocation. Always dislocate only when you see at least 50% of the head. And dislocation should always be done by the surgeon, not the assistant, because he knows how much pressure is to be applied to dislocate. Any overzealous attempt can lead to fractures. If by all these methods, if it is not possible to dislocate, then cut the neck and then remove the head. While we do the reaming, we only have to ream the peripheral one. Never try to ream the medial wall. Always remove the tissues from the medial wall using any sort of scoops and something. Remove also of tissues that will help in impaction bone grafting. But don't ream medial wall. Most of the time it is very flimsy. Try your trial component and see its fitness. If it fits nicely, then go for uncemented one. Then do the impaction bone grafting. First pack the cavity properly, impact it, and do the reverse reaming. After reverse reaming, that sets properly. Once impaction bone grafting is done, use final implants. Once you impact the final implant, you can see after impaction of final implant, it also helps in impaction of the graft more firmly. Then reduce the joint. These are some of the cases. This case is done recently with impaction bone grafting and uncemented cup. In this case, the cemented cup is used as a sandwich technique. Impaction bone grafting and cemented cup is used. You can see the 3-month follow-up where you can see the good consolidation of bone, good consolidation of medial bone and restoration of medial bone stock. This is the case of acetabular fracture where impaction bone grafting and multi-hole cup is used. This is the case number 4 where impaction bone grafting and cemented cup was used. Thank you.
Okay, thank you, Ratnesh. I think that was a lot of useful tips in that short talk. So any questions? We'll open it for questions from the delegates or from
Yes,
the
sir.
participants.
I think from Gautam, sir, what is 0 grade to means AC2 classification he has written. What is the grading? How to grade it?
Grade means classification.
Yeah, you want to ask Gautam?
सर गुड इवनिंग
Yeah.
Good evening.
सर जो क्लासिफिकेशन आपने बताया उसमें ग्रेड 0 था सर जिसमें डिस्प्लेसमेंट वाज गिवन एज नन
So the
Zero.
Chamley classification.
देयर इज नो medial displacement according to x-ray then why it is protrusio sir
No, it is not protrusio. There are many classifications where you consider normal as 0.
okay okay sir and sir in every protrusio cases do we need impaction bone grafting
Yes, our target is to achieve. No. Sometimes sometimes in grade 1, if you don't do the impaction bone grafting and you use the uncemented cup,
yes sir
bone will automatically form. Sometimes bone, if there is very small cavity, bone will automatically form. But in grade 2, grade 3, yes, either you use uncemented or cemented cup. You have to do it impaction bone grafting.
I think even in grade 1, you have to be careful that you don't medialize the cup, okay?
Yeah.
Because you need to make sure you ream peripherally only, and you get a very good peripheral fit for the cup. If you hammer it in all the way, then it's going to go back into a protrusio position.
Another important advantage of impaction bone grafting is that it helps to maintain the hip center.
Yeah.
If you don't graft, then there is high chances of medial migration of cup even after surgery.
Exactly.
So you have mentioned about protrusio cage. So what is the indication for that, sir?
Main indication of protrusio cage is pelvic dissociation. If there is medial gap is more than 3 centimeters, it is considered as dissociation of pelvis. Means ischium and ilium and other parts are dissociated. There is no much strong connection between the two. In that case, you have to fix it either by cage or you can use the posterior plate or other plate to make the pelvic continuity first. And second thing is when there is no rigid support, suppose there is nothing in the middle, how will you impact? More than 3 centimeter gap you won't be able to impact the graft. Then in those cases, you need a very rigid support by the time the graft heals.
So we can reconstruct it and then put it, sir. If it is
First put the bone grafts, then cage, then again bone graft, the holes, then cemented cup. Then you have to cement the cup in proper position over the cage.
And so you mentioned about that we should not ream the medial wall. And in another thing that we should see the bleeding points before putting the graft. which is usually we do. So in these cases, sir, how to decide between these two? Like,
No, you can remove the soft tissues from there. Any attempt to remedial wall will lead to the breach because they
So
are very
you'll-
sensitive.
So it's a choice between having a medial wall at all or not, okay? So if you try to ream a really thin shell, the reamer is going to go right in, and that I've seen that happen. So you have to be very careful about it. So I think, yes, you remove all the soft tissue, but so you'll see bleeding bone all around the periphery. But in the dead center part where you're on the fovea, you'll hardly have bone. Sometimes you'll just have a membrane. You may not even have bone. So if you don't have bone, then you might have to put some kind of mesh or something to support that. Especially if you're using impaction grafting, put a mesh, then impaction, and then your cup.
and so, like in normal cases, sir, how to decide how much medial wall to be reamed? Because we have seen few of the X-ray which is after THR patient has protrusio. So to prevent those things, sir, how to decide how much medial wall to be reamed?
So if you follow your basics of THR, the fovea is the innermost portion that you go to. So you need to get to the fovea, but not beyond that. If there's already protrusio, then you have to watch it on C-arm and then do it.
And one more thing, sir, when there
So the
is
ilioischial line, the teardrop, are your guidelines not to go beyond that.
yes, sir,
Sir,
when
in
there is
bilateral cases, sir, a reference point क्या लेते हैं?
Reference point for what?
For cup positioning, if
For
also
cup
there is
positioning, the cup should always be just lateral to the teardrop, whether it is a protrusio acetabuli or in normal condition.
So that's your landmark. And usually the ilioischial line you'll be able to make it out. Okay. It may be broken in between, but you can see the proximal and the distal part of it, and also the teardrop.
okay, sir.
So, sir, good evening, sir. So,
Yeah.
sir, when the wall is already medial to the teardrop, so in that case, we should not ream at all.
So you need to get the medial wall onto the teardrop. That means with the impaction grafting, you have to get the cup out
Yes, sir.
to a position where it can go beyond the teardrop.
And in that,
To
in
be
that case,
supported. If it's not supported, it will tend to go in.
sir, in that case, the reverse reaming you do after the bone grafting, that is not done in this case.
Yeah, you do that, but so when you're reverse reaming, it's not going to take off all that graft, okay? But you need to get adequate bone there. So first you punch in whatever bone you put initially.
Yes.
Of course, if you have a defect, then you need to put something to support it, okay? If you have a defect and you put it in, then it's going to go all the way in. So you put a mesh or something to support that defect and then put your graft.
Yes, sir.
so, while putting the bone grafting, sir, how to know that it is adequately impacted? So how to decide that it is not impacted more or less? Like you have mentioned about the reverse reaming, sir.
So you have to be careful when you're doing it, and you should get a clear sort of, it becomes like one surface. Okay. When you got your bone graft, it's in multiple pieces. When you finish reaming, it should be like one surface onto it, reverse reaming. And be careful not to, by mistake, do reaming in the normal direction, because then it will chew up all the bone that you've got. And you lose that bone.
And
You have to
one
go
more,
slowly, press too hard.
so one more problem about that, if there is a fracture in the acetabular ream, sir, so what are the options we should have to manage those?
When there is acetabular fracture, it depends whether it is acute fractures or there is some malunion. If the fracture is united, maybe malunited, then you have the support, you can do the impaction grafting and directly use the uncemented cup. But in cases of fresh fracture, you have to fix the pelvis. Either you plate it first, plate it or screw it, whatever you want. First, you have to make it strong, make it rigid fixation. Then you can do the THR.
So just day before yesterday, we did one where we fixed there's a big posterior wall, posterior column, and anterior column. So transverse with posterior wall. So we first fixed the posterior column, then we put a screw for the anterior column, and then did our THR, that too with impaction grafting. Okay, so that's, you need to, where the fracture is not united, we'll have to fix the fracture. If it's an old non-union, then you may even need to graft the non-union along with your fixation, and then decide whether you want to do it in one stage or two stages. That's up to you. That will depend on how much the patient can take or how much you can do it one go.
And if it is just acetabular ream defects, then what are the options? Like if it is defect is in only acetabular ream, otherwise it is.
There are multiple options. Whether it is, it depends whether it is fresh fracture, like you are talking about the posterior lip fractures or superior lip fracture. Either you can fix it with the plate, that will make the rim stable. Second option is, suppose there is defect which is not amenable to fixation or it's an old gap. Then you have to use the mesh, fix it, do the impaction grafting, and then use the clip. Then you have to make the ring full by grafting and mesh.
Because if it's unstable, then your joint, your cup will loosen in no time.
And so any option of cemented cup in case of protrusio?
In grade 1, you can use it only cemented cup.
Yeah, you can. You can use cemented for anything. You need to impact. Even for grade 2, you can do it, but you need to make sure you do enough impaction grafting to get the medial wall to the correct level. Otherwise, if you just try to fill it up with cement, it's going to fail.
So it's always with bone grafts, whether it is cementless or cemented.
Ideally, I mean, I know people who've just put cement. It will last for some time, but then it's going to give you problems. So
medial bone grafting is must actually, because we have to maintain the medial bone stock, because this is the first primary THR. There is high chances that it will fail in next 15 year, 20 year. Most of the time patients are very young, like 35, 40, even much younger also. So we need that bone stock. Once the bone stock will be there, suppose your primary fail, you will have the bones for future revisions. If you don't bone graft, then it will be a much dreaded situation for revisions. Even sometimes we use the cage in primary, we use it. In that case also, by the time it fails, you will have the medial bone. So after removal of cage, you can implant the normal cup also. That doesn't mean you need to use the cage again, because you will have the bone in the medial side. So medial bone grafting is the mainstay of treatment, whether you use cemented, uncemented, cage, anything.
So just one last question, sir. If we are not able to see TAL, then how to decide where to put the cup or the orientation?
TAL is mostly preserved, and sometimes you have to put the cup in a standard 20-degree anteversion and around 45 degrees, 45 degrees inclination.
And when
so TAL is there more than 95% of the times, okay? Now, in primaries, revision is a different situation. And your orientation, you have guides to help you orient. Most of these cups have certain guides which will give you. You look at the iliac, anterior superior iliac spines, draw a line to that and keep it at 45 degrees to that. And version you check, depending whether you're doing in the horizontal plane, then you check with the horizontal. If you're doing in supine or if you're doing it in the lateral position, make sure the patient is dead lateral and then you antevert the cup accordingly. Okay. If you're doing posterior, then this becomes even more critical. If you're doing an anterior approach, then maybe a little less inclination, a little less version will work. But if you're doing posterior, then your anti-version is very important. Otherwise, it'll be unstable.
I think most of the thing we have covered, sir. And if
By and large, you have to try to restore the normal inclination and version of the original cup. Okay. Then it.
I
Okay.
think
So great. Thanks very much, Ratnesh. That was brief but excellent. And hopefully we get our program back on track. So we'll have something next week. Presumably we'll work out what we do.
thank you
Okay.
so much.
Bye, everybody. Bye.
Thank you, sir.
Okay. Thanks for
Thank you,
patient.
sir.